welcome all the brave ones that had the stamina and the strength to stay and hopefully make it fast. But I believe it's very important to also mention the other technologies that will be shown tomorrow. And it's my great pleasure to chair this session together with Alat Anter, you all know. And I will introduce him directly because I believe he has the first lecture in this part, which will deal with the AFERA Sphere 9. Thank you. Alat.
Thank you, Peter, and thank you, everyone, for staying late. So I'm going to be talking about the AFERA system, and particularly my task is to cover atrial tachycardias. So my disclosures are that I was involved and I had equity in AFERA, but it's already Medtronic, and I don't have any equity with Medtronic. So I think I can move on. So the content, I think most of you know the system, so I'm briefly just going to cover the AFERA mapping and ablation system. I'm going to focus a little bit about activation mapping, including the integrated stimulator, the pacer that this system have, and it's a unique feature for a 3D mapping system. And in particular for the activation part and the pacing part, which is great, but there are also challenges and room for improvement. And I'm going to show some examples. In regard to the ablation using PFA and RFA on the same catheter, same platform, we'll talk about the approach, the technique, and the potential durability, or maybe lack of durability for certain arrhythmias. So starting with the technology, I think you all have seen this before. I'm sure many of you have used this technology already. But the whole technology is based on the Sphere 9 catheter, which is an 8.5 French bidirectional catheter that have a lattice tip that form like an electrical current cloud. It has 9 mini electrodes that serve not only to record and to pace, but also as thermocouples to measure temperature. It has a central reference electrode. So each of these electrodes on the surface creates a bipole with an electrode that is inherently not touching anything. So you can call it like a local unipolar electrogram. And the basis for why this technology was born is to make big lesions. And the reason it makes big lesions is the limitation of the standard 3.5 millimeter catheter, that due to its relatively low or small surface area of about 28 square millimeters, you can't really push much more than 600 to 700 milliamps without exceeding the current density that would lead to a stim pop. So that's the limitation with the 3.5 millimeter catheter. When you create a catheter that is self-expanding into a surface area that is nearly 10 times as big as the standard catheter we used for point-by-point ablation, then we can drive 10 times more energy and still have a much smaller current density. Now, in reality, the idea was to create a large footprint catheter that will allow to make more contiguous lesions and reducing the number of potential gaps. And doing this also quicker because you can drive more current quickly and safely. So the console is actually very nice because it's on a cart. It has the mapping system. It has a PF generator, and it has an RF generator and a pump. And with the same catheter, you can create a high-density, high-resolution map. And you can also ablate, and you can ablate in 2 different modes. It started as an RFA technology that then evolved to be also a PFA technology. And you can switch between the generators by stepping on the pedal. When you use this system as an RFA, it's 5 seconds per application. When you use the PF, it's 4 seconds per application. It's a monopolar system, and it's a biphasic waveform. We published this IDE study a year ago. I think you all seen it. I'm very proud of this illustration that I kind of like made myself. But in any way, what this illustration came to show is that you have more overlap between bigger applications, so the risk for a reconnection is smaller. The other thing is that you can only introduce one catheter into the left atrium for mapping and ablation. You don't have to introduce a separate mapping and a separate ablation catheter. And I think you all seen these results. The study compared, it was a randomized control study that compared the Sphere 9 and the Affera system to CARDO 3 with the STSF, and it showed non-inferiority. So meaning in patients with persistent atrial fibrillation randomized to undergo AF ablation, it did as good as the CARDO system, potentially even a little bit better. Now, when we look on this data, we can see that what else these physicians did in these cases. So PVI was mandatory. Lines were actually discouraged, but they were done. So in the controlling the CARDO system, 85.6% of the patients underwent ablation beyond PVI. But what was this 85%? The majority had CTI, 10% had mitral lines, and about 70% or 65% had roofline or posterior wall isolation. What about with the Affera system? Nearly all the patients had something else done. But yes, they did have CTI, but the big difference is that many more of these patients had posterior wall and mitral lines. Now, why? And the second question that you may have in mind is that does this explain the difference in the results? So I'll start with the second question. The second question is that no, we did some sub-study analysis, and the additional lines did not contribute to the difference in the groups, at least not statistically. Now, the first question is why people did with this new technology that most operators did on average 5 cases, as opposed to the 100 cases they had under their belt with CARDO. Why did they choose to do lines with this system? Because it's easy. And when you provide a physician with something that they can, do things quickly and in an easy fashion, they tend to do it with evidence, without evidence. But that's the reality that we live in. Now, this is an example of one of my cases, but in general, this is how a 40-minute case looks like. You can do a PVI, you can do a roof line or isolated posterior wall, you can do a lateral mitral line, and it's easily achieved in most cases. This is from a different study we published, and here, that was the early phase of the system development when we compared different sequences of PFA. But the bottom line, what I want to show you here is that in this remapping study, so many of these patients underwent remapping, CTI was isolated in 100% of the patients. Roofline posterior wall in 100% of the patients. Mitral lines in nearly 90% of the patients. So overall, you have 91% of durable lines. So when you have something that can make almost like, a catheter-based maze, it makes, and this paper was published before the IDE study, so it made physicians feel confident making more lines with something that seems more easy and durable to do. So most cases, you can get like very nice PVI and mitral line and posterior wall isolation. This is a case when you have mitral flutter after a PVI and posterior wall isolation. We made an anterior line. We confirmed that we have block on the anterior line, Actually, we map the right and the left atrium. And in the same patient, we also induce CTI at the end, and you make just few lesions to complete also a CTI. So there is a strength to a system that you can map, remap. Everything takes small amount of time, and and ablation is relatively fast. And let me skip this one. But I want to tell you something. When this system came out, you know, what was sometimes very easy in IDE studies or in first in human, you start to have more exposure in real-life patients, and it's not all the cases are like this. And actually, I'm going to show you things that are not like this. And this is one of the cases. So this is a case from like a week or two ago. You have your patient that underwent PVI, and you can clearly see that you have a clockwise mitral annular flutter. We make the line during actually the flutter. The third lesion here terminates the tachycardia, and we confirm a block. Great. This is like the study. But this is a case from a few days ago. Same thing, clockwise mitral annular flutter. See how many lesions I put here. You remember how many lesions we had on the lines that I showed in the papers, the lines that I showed you in the first case? How many lesions do you put, Peter, in like mitral line? 5, 6? That's usually the number of lesions that we put. In this patient, younger patient, 42, 43-year-old patient, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 lesions. It's a lot of lesions for this small space. And I can get a block. I can get a block. Like you can see that there is a leak. I'm pacing from the CS, and there is a leak. I went to the CS here, and I applied PF lesions there. The PF lesions are only 1 second. I could hardly actually finish the PF lesion. I think it stopped nearly close to the 1 second because of overheating. Because it still hits if you are in a small coronary sinus, particularly when the catheter is a little bit compressed there. So did we get a block at the end? Yes, we did. We got a block, but it required 19 applications, 12 endocardial RFA, 3 endocardial PFA, 4 CS PFA. That's a lot, okay? Now, you can say, who cares it's a lot? Still, it's very quick. I do care, because these lesions, they have a lot of current that you deliver into the tissue. We don't have experience putting so much energy into the tissue. Is it safe to do? I don't know. And if the block that you get at the end is with the PF lesions in the CS, does it mean that it's going to be durable? We don't know. And waiting half an hour, giving isoprel, it's not predictive. So you leave the case where you don't know. And the take-home message for me is that no technology is perfect. It's very good. But there are still things we don't understand. And actually, I looked up to see if I'm the only one that's failing in those cases, at least in some of these cases. And I see that actually Pierre Jaïs published, and Dorval from Bordeaux published a similar case. They did a PFA mitral line here. They showed, it showed recovery of this line after a few minutes. And they had to do vein of Marshall alcohol ablation, and that's what led to the persistence of this block. The other thing I want to show you is this, and it's the electrograms. So this system was built initially as a 3D mapping system to build anatomy, get information, do ablation. But it wasn't like there wasn't a lot of emphasis that was placed on the mapping. The mapping was just inherently good because it's a good catheter and the electrodes are very small. But here I'm now showing you electrograms from an isolated pulmonary vein. This is the left pulmonary veins. The catheter is in contact, as actually shown by this green overlay. The green part highlights the electrodes that are in contact. And you can see that you have relatively high frequency electrograms there. And when you look on the posterior wall, you see that you have some green color. It's not red. Why is it? I don't know why it is, but we pace. And when we pace, we see that we don't capture. And when we look for the source of this electrogram, I don't have this slide here, we paste from a second catheter in the appendage, this disappears. Now, I must say that I was a little bit surprised because you would expect from very small electrodes not to pick up the far field from the appendage, but you do pick it up for some reason. Why? I don't know, but I think it's something that needs to be worked on. The other thing is that, and I'll be interested to hear Peter and other people experience, is the pacing part. The system allows you to pace, which is great. So you don't need to ask anyone to pace. You can put the sphere 9 in the veins, pace, and see you have exit block. But there is a lot of saturation and a lot of artifact after the pacing that you can imagine that if you wanted to entrain at low output, and this is actually, this pacing was, we reduce it here. What you see here is like 2 milliamps. So it's relatively low amplitude. You have too much artifact to what you want to have when you're doing pacing maneuvers. So to conclude, I think the Affera system and the Sphere 9 catheter, I think they're a revolution. I truly think so. Like, you know, it really makes mapping and ablation much easier and probably more effective. The system seems to increase PVI and line durability compared to what we know. However, real-world data is needed to determine the actual durability and to optimize strategy. And I do think that it requires now, after it's already commercialized, many more centers have been using this. I think the company needs to work more on the mapping and the pacing capabilities to bring this part of the system to match the ablation superiority. And I'll end here for time. Thank you.
So we should have the discussion at the end, but I believe at least 1 or 2 questions we can handle now because the topics are different. So just to have some thoughts about what you've mentioned, I still believe it's a revolutionary system. I'm really happy that we have it and that allows us to treat some arrhythmias that we were not able to do before. Obviously, you tackled very important points like how to do the linear lesions, whether we use pulse field, whether we use RF, how much is safe enough to do it. But I really remember times that we were not even able with 19 lesions, even 30 lesions to really block the mitral isthmus. So I believe we are getting there, but we need a good recipe how to do these things safely, effectively, and have a durability. My feeling from my experience is that the linear lesions on thick tissue like mitral isthmus with pulse field is not good enough, especially if you go only endo. It may be working acutely, but the long-term effect is probably much lower than we wish to and desire to have. And also, yeah, the CS application makes a lot of sense. Although it might come with some challenges how to get there and the risk of spasm. But yes, there is. On the other hand, the far field thing, the mapping, well, yeah, you always have to interpret the maps. There are many things that should be improved in the system, and I hope that will. For example, we use it for the ventricular tachycardia. That is, if you go epi with the Affera, it does you only the outer shell. What you look for is the inner shell of the epicardial surface, for example. So there are a lot of software things that should be improved, but nevertheless, I believe, at least we have the commercial use for the system for a year and a half now. And it really helped some of the patients. We couldn't really do it otherwise. At the 3 previous procedures, we couldn't really do it, and it was like that, and that did work. So that should be also mentioned.
Absolutely, Peter, I agree with you. For the sake of time, I'm not going to
Okay.
respond. So it's my pleasure to invite Peter to speak about another Affera product, and it's the single-shot Affera 360 for AF ablation.
Okay, so I've tried to make it quick, and just this won't be that much personal experience or nice maps because we were limited only with the study to use this. So Affera has a nice wide kind of footprint catheter, so why should we have the single shot? There are a lot of different catheters. It's sometimes difficult to make a your way around it. But truth is the single shot catheters demonstrated reproducibility. This is from the cryo times when the cryo was compared to point by point, and generally it shows that there are some centers that do very good point by point, and they've spent 10, 15 years to master their skills. But there are some that may be starting and they never have a capacity to really run that well. So the range of kind of variability in point by point, it may be quite high. On the other hand, if you have something on the wire to bring to the vein, you can probably, with a much shorter training to do. The question is whether it's good to have young EPs then they know only how to do single shot devices. Probably is not good, but for their everyday practice, it's something good to have. So that's why this is something that will come for Affera. It's something that looks like a Sphere 9, but it's somehow, imagine it like something bigger and more softer, kind of lighter version, but much larger. So it's not 9 millimeters, but it's 34 millimeters. And it comes with the over-the-wire, and it can create different shapes. These are 3 different shapes, but obviously it's everything in between can be created and somehow be in alignment with the pulmonary vein. And there are 6 bipolar electrode pairs providing mapping and stimulation, and single transeptal puncture is needed for Agilis. So this is in detail. The catheter, the electrodes are distributed in 6 sections. There are about 4 applications per vein. There is a magnetic sensor which allows a precise tracking within the magnetic system, and each application, which is monopolar biphasic, it's 5 seconds. So I will just go very quickly over the data that was published about the system and the catheter. So this is the first data paper that was published by Vivek a year ago on ERA, and it included data from 3 centers, including ours. And there was 85 patients with single transeptal. And this was the kind of outline of the study design. So there was the mapping, so it was the ablation, and there was an optional remapping, which I believe was crucial for understanding the outcome of this. And there was a follow-up for 1 year. This is how it looks like when you use it. So it creates the 3D reconstruction. This was created all with the Sphere 360. And the catheter is very nicely visible on intracardiac echo. This is how it looks like on X-ray. It's a very fine material, so maybe not displayed in this picture, but obviously can be seen. And this is how it looks like in clinical practice. So you can do the map pre-ablation, then visualize the ablation tags, then you can remap post-ablation. And obviously this was a successful 75-day remap, and all the veins remain isolated. What I would like to highlight about the procedure, because it's over the wire, so it's only to bring the wire into the vein, and then just do the ablation 4 applications per the vein. It takes only 10 minutes to finish the ablation. So its PVI transport time was 10 minutes. And the whole LA time was 20 minutes, because you have to do at least some mapping, just the veins, and then do a remap and test for the reconduction using adenosine. And so that's pretty fast. It can be done very quickly. What's very important was this remapping part, which allowed to optimize the system. I believe a lot of these catheters should undergo this mandatory remapping at 75 days or 90 days. And obviously, seen the first iteration was not that good, but the last one, incredible at 99 success rate per vein, which results in 96% per patient. The catheter turned out to be extremely safe. There were no major complications associated with the use. There were also a portion of patients underwent the MRI scanning, and there was some changes on the MRI, but it was in the level of what you have with the other PFA systems. So this is the more recent data published, so already 100 patients with all the follow-up. The largest group is the optimized Pulse 3 kind of group, which patient also had an implantable loop recorder, and this is all the data durability with the pulse-free nearly 98%, which results in 93% per patient. This is per vein. This is the old image you've probably seen, different technologies with the radio frequency on the remaps, a frequency of patient with all veins durably isolated. This is what we did for 10 to 15 years. This was some of us were somewhere here maybe, but most of it was somewhere here. With the balloons was not much better. With the PFA came and was much higher. This is obviously data for pentaspline remaps, and Sphere 9 is somewhere close to it. We can discuss whether this is really, it's not direct comparison, but I just want to show this. This is the recent trial from the PFA kind of catheter, which had the remaps, and so it's not the kind of the energy source. It's more about the optimization of the energy source, because the catheter didn't undergo these rigorous remapping studies. So just to watch for this. If you ask where are the reconductions with the Sphere 360, it was published. So it's generally it was the left vein somewhere in the superior anterior portion of the left veins, and these are the outcome data for the follow-up. So if we take only the optimized pulse-free kind of cohort, you ended up somewhere at close to 90%. Obviously, these are patients that were ablated in experienced centers, and but with image integration because it's 3D mapping system. But this doesn't mean that it was not successful for 12% of patients. There are data of the decreased AF burden in patients even with recurrences. The daily AF burden decreased dramatically, and this is demonstrated in here. So there, obviously, what you want to have in a loop recorder after your ablation procedure is a lot of arrhythmias before and nothing for the whole year after. This is the success. Obviously, there are some unsuccessful story in terms of the primary endpoint, which is a lot of success, and then at the 9 months is one episode, a few minutes or dozens of minutes of the AF, and then nothing. So this is calculated as a failure, although for the clinically for the patient means a lot of success. And there are also patterns like this, that there is success for some time, maybe drug was stopped and there's some recurrences, or there may be something like this, that there's nothing and suddenly you have a late kind of recurrence. Maybe it's a progression of the disease, and maybe just PVI is not good enough. But this is maybe just a thought-provoking slide to think about what we have as endpoints of these procedures. So let me conclude that this catheter will come to the market, be free of use. It's evaluated. It's a single-shot catheter that not only allows ablation, but also within the system allows the geometry reconstruction, voltage activation mapping to some degree. It's not the high density, but for the, I would say, kind of rough estimate, it works pretty well. And obviously, it's used for ablation. And these studies show that it's a very highly efficient, safe, and effective. Thank you for your attention.
Very nice, Peter. Any questions from the audience? Go ahead.
And a specific protocol in terms of the shape of the device you used?
So tomorrow, I just didn't mention that tomorrow will be a pre-recorded case of the Sphere 9 at 360 showing exactly the workflow of the catheter, so I didn't went too much into the detail. Let's say that you put the catheter maybe a little bit more inside the vein, make it smaller, and you apply 5 seconds, then you withdraw a little bit, few millimeters, like usually within like 5 millimeters or 5 millimeters, you expand it a little bit, you make another lesion. So 4 applications like this sequentially coming from the more distal part to more proximal osteal part, and that's it, and then you move. So generally you don't create a map, the whole, you don't have to, you just go to the vein, and on the go you ablate and you create your geometry, you go to the left inferior, on the go you create the geometry, you ablate, you go to the right, so within 10 minutes you're finished. So that's pretty fast, and due to the remapping studies we know it's very effective.
You showed that you can pretty nicely change the shape of the device.
Yeah, like adapt. If there is a left common, if it's a small vein, you can adapt that. Okay. But generally, the workflow is a little bit more inside, smaller catheter, and bivirtually, and the system shows you the distance to the previous lesion. So this will be shown tomorrow, so stay tuned for this. There will be more in detail description. Okay.
Thank you, Peter. So I've been told that we are going back to Homolka for a live case.
No.
No?
A lot. No.
Oh!
No live case. I'm live. It's a no live case.
You're live.
Okay.
You're live.
No, it's presentation. You know what? Okay?
Presentation.
Guys, you are tired. Okay. So. Okay. So a lot, Peter. I will be very fast. It's my honor to, on behalf of my all colleagues mentioned here. So it's a presentation about nanopulse technology, which will be actually shown tomorrow morning. We a little bit change the schedule because of Vivek is leaving early afternoon, so we show the case tomorrow morning. So this is very early data from the feasibility and durability of pulmonary vein isolation and posterior wall ablation with this nanosecond pulse field ablation system. So disclosures. So what is the catheter about? Okay, so this is a very, very tiny catheter, like 360. Actually, Peter showed 360 sphere. So this is a 360 degrees catheter named cell-fix, but doesn't matter the name. And the catheter is actually constructed with two rings. Okay, the outer ring is 30 millimeters in diameter, and the inner ring is 22 millimeters, and in between the rings going to be ablative pulse. So actually all this okay, mouse is visible, fine. So all this circumferential virus are very active, and on top of this ablative virus there are 12 sensing electrodes. Actually, 5 as a pair on all the digits, and 1 pair is on the shaft, which help you to visualize the system in every single electroanatomical mapping system. So actually, but when it's indicated here, the pulse field is like volumetric. And what is about why nanopulse? Why not micro, why nanopulse? The nanopulse has some preferential. So one, most wish parameter as actually it's a little bit similar as the technology Vivek showed you this morning, is that the depth is much larger. Okay, look at like in preclinical experiment, we did a lot of animal preclinical testing, and the depth is around like 8-9 millimeters. And actually, it's more about the nanopulse. It's not only the depth; it's actually the nanopulse irrigate the muscles less. Okay, so we wish that patient doesn't move too much, okay, when he's going to, the procedure in consent sedation. Actually, we are using just train of pulses. Actually, during the study, we did 2.5 and 5 seconds pulses. Actually, I believe that I will show you that 22 or whatever the patient cohort with only 5-second pulses. And actually, we do most of the procedure in consent sedation or deep sedation and or in anesthesia. And actually, when we use this, the very first in man study, we use several of this mapping system to be comfortable to visualize the catheter. So we try to understand which of this mapping system is the best. So the nanopulse, when I mentioned this, the categorization of the pulses. So nanopulse maybe is more non-thermal, because we know from all the pulses, for example, again, Afera with the micro thermistors indicate even, some temperature rise, and it's always important to be on the safe side. So the thermal effect is always in, even with, pulse technologies, but actually it's not ablative. So if it's not reaching 50 degrees. So this nanopulse is really, nanopulse and nanosecond pulse is really like non-thermal. This is very important. And the structure of the cell is a little bit differently affected by this nanopores, and actually it's safe even better these collateral structures. So this is, I need to move it, right? So this is just like the movie to show you the workflow. So usually we have like PRAGUE, and like as usual, we have eyes to control the positioning. I hope that this eyes is again in the left atrium. No, it's not. No, it's the right side. And actually, we have the catheter in the body. Actually, before we map, we can map. Actually, we can map the electron mapping. We can do with this catheter and or with dedicated other catheter. So, for example, catheter we can use octary, but we can even use this catheter to build up the anatomy. So, which is important. So, right now, the latest procedure we did with a little bit customized catheter system, which is adapted for this, or built up for this, adapted for this catheter. And I will show you more importantly, which way we place the catheter actually in the vein. So actually, when we are speaking of PVI, so this shape we call this shape like mushroom. Okay, so we really want to get this two rings like separated. So if you have this two rings in the contact, you can get arcing. So you cannot deliver the energy. So you need to be sure the proper placement. So in this fluoro visualization, you can appreciate that you need to control that the two rings are not in the contact. Then you cannot deliver the things. Now, well, it's somehow about like all this placement of the catheter. So usually we apply 2-3 lesions per vein. Okay, so it's not need to go for, it's not like single shot. I need to explain that it's not like single shot technology, but actually we really minimize the number of applications per vein. And then we can expand, as the title of the presentation is, we can expand even for more antral and actually even for a posterior wall application. So this is first immense study. So we did, okay, I was correct. So 22 patients with different mapping systems. So to adapt the visualization with ablation 2.5 and 5 seconds, but majority of these patients were done by 5 seconds pulse, and actually we did remapping in the 2-3 months. So to shorten the presentation, I will show you just the examples. So this is like example, the acute post-map with NavHex, and this is post-map with a cato it's like several months after the procedure, and this is all this characterization. So remap indicated actually we reach acute isolation was like 100%, but actually we don't care about this acute isolation. So more importantly, we have like this remap data, which was really encouraging. So like 94%, 95% for PVI, and actually 95% for posterior wall isolation, and you can see this timing. The problem is that it's study and this first immense study, so I wouldn't even rely on this timing or the total procedure time, which is not very important. But you can really appreciate that even we didn't use since the beginning, dedicated mapping system. We use some mapping systems, but we have really very, very highly acceptable low fluoro time. So this is one of the examples I will show you, I hope, 3 examples. So this is post-map, acute post-map after the procedure. So it's like PVI plus posterior wall. This is 80 days remap doing with Carto. Actually, we have no touch-ups. In this case, it was like 115 minutes per this case, and actually we have 8 minutes using 24 minutes for the dwell time. So this example is the second example. Actually, the map was done like actually in the same fashion. So it's carto map for both situations, acute and this remap, and it's even less fluoro time, and actually we really decrease the time for the total procedure time, and actually we have no any touch up in this case. So for sure I'm not showing the bad cases, I'm showing the best cases. So we can openly say that we are not so perfect, but really not, we are not 100% successful in remaps, but we are very successful. I really want to show you this example, which is a bizarre map, and this map is like acute map is done. Carto NXT, so like it's not it's like a different mapping system. This is 50 days after the procedure. Actually, this is a funky, very unusual vent going in the top roof of the right side, more or less the right side, or in the mid of the posterior wall, and look at the mapping times, like fluoro time is like 2 minutes. So actually, again, no touch-ups, even with this funky, very different, difficult anatomy. So in conclusion, I would say that this PFA nanosecond pulse circumferential catheter was successfully used, but actually we have the learning curve, and we need to expand with the number of cases right now with the customized Carto cases, so which allows us to use dedicated electroanalytical mapping systems, and we really need to get for sure with randomized controlled trials for the enlargement of this ablation technology. So I didn't mention, actually I did mention the number of actual applications per vein, but actually we don't need to apply too much more for posterior wall. Actually, the average is like several more regions. So it's really, this technology really minimized the number of applications, and we haven't seen any hemolysis. We check for hemolysis, we check for the labs, and actually we couldn't, we cannot conclude right now, but I hope that we can indicate this pulse field technology allows you to avoid this complication. Thanks you for all the attention. Thank you.
Thank you very much, Peter. Any questions?
Any acute questions? So maybe I will have one. Have you tried to ablate the atrial flutter, typical CTI? Because
actually we tried. Actually, it was not included in this study. Actually, this cohort we tried, and it's dependent on the sheeting. Sheeting is like easy, so I think you can avoid the potential AV node ablation, because it's very, very important to be away. But actually, it was not the purpose of this first human in the man study. So in these 22 patients, we didn't perform any of this CTI. Okay.
Okay, thank you. The question and the reason why I was asking is that some of the technologies is just PV only, and some of them can be very versatile, I believe.
Yes.
At the end of the day, those that are versatile can be used for most of the targets, probably going to be more successful. But maybe I'm just not right.
No, but actually, Peter, you are right, because we showed the case. Today with FRAPulse, so the different technique how to apply on the CTI, even with the current technology. So that pentaspline cutter you can use like flower, you can go like powerball, you can go like basket. So actually, it's adaptable. So we all need to learn how to use it, and this is a very early data. So I accept this is a very important aspect for complexity. So we need to be able to go for flutters in the end of the day. So I hope that I can answer yes, but we need to have the data.
Okay, thank you very much. Are there any questions? If not, I would ask Gabor Sepaki for his lecture on STSF, PFI catheter, Biosense Webster.
Okay, thank you. Bye-bye, guys.
you.
See you.
See you
See
soon.
you at the party.
Thank you very much, Peter. Thank you, Josef, for the kind invitation. You can see the slides now. So just some disclosure. So thanks very much for being here. I'm going to talk about the Carto Smart Touch SF Dual Energy Platform. And just to start with some disclaimers, this is a technology which has a CE mark, but hasn't been commercially released in Europe. And it's not approved in the US or Canada and Australia. The study is still ongoing. I hope to be in a position today to show you some cases, but unfortunately the launch has been delayed, so I can't show you some nice examples. I was planning to do a completely off-label left atrial tachycardia just to cheer up the day after so many PVIs, but that's probably for next year. So the good thing about the technology is you're all familiar with the catheter probably, and you're all familiar with point-by-point ablation. So transitioning from the old RF technology to this new platform will be very, very easy. You will have the catheter. You all know it's a nice catheter. It has contact force sensing. It's an irrigated catheter. And what Biosense has done is it has integrated a PF generator into the equation. It's called a true pulse generator. It's the same generator as we use for the varipulse cases, so you don't have to buy two capital equipment for the same. And one of the big advantages is it's fully integrated into the Carto system. So let's say we've seen a few cases today. You don't have to switch off and on the system during the case. During ablation, you will see the catheter live. You will see if the catheter moves. And I think that's certainly one of the advantages of the true integration. Now you will have to get a new connection interface unit, the true pulse connection interface unit. And that will be allowed to seamlessly switch from RF to PFA during the case, and it will handle all the other connections. You will be able to use the standard HD mapping catheters, which are commercially available by Biosense Webster if you're using this system. So up to date, there's more preclinical evidence or data available on this technology, and much less clinical studies. I'm going to show you some slides about the SmartFire trial. I was one of the investigators, but that is the only clinical trial that we have available right now. As I already mentioned, the SmartPulse and the PulseSmart studies are ongoing in the US and Australia and Canada, and they are the labeling studies. There is a very interesting study, the GP-Fire study, which is ongoing in Aalst. And tomorrow, I believe, Tom the Potter will show a recorded case, and it's a quite interesting study. They're randomizing patients with RF ablation only versus RF ablation plus pulsed field ablation versus pulsed field ablation only in terms of pulmonary vein isolation. And the other interesting trial, which is ongoing right now, is the dual VT study, which will explore, the use of the catheter in a ventricular tachycardia setting. I'm not going to show you all the data on the preclinical studies, but I think there are some very interesting and important studies or results which you have to know before you start using the technologies. And I think we mentioned it already that pulsed field ablation is not like one size fits all, and you have to reproduce all the preclinical data if you're producing a new platform. And I think that's very essential because you can't generalize the results. Let's say if you have one catheter from one company and another catheter from the other company, the formula of the PFA, the energy what the PFA generators are using are completely different, and they will translate down into completely different lesion formation. And this study, I think, is quite interesting. I'm not sure if you see the pointer, but anyway, so this is basically a dosing study which investigated the magnitude of the number of burst impulses which you can deliver with the catheter, and it also investigated the role of the contact force. And as it looks like in this configuration, both of them are very, very important. Okay, so then the more impulses you give with the catheter, the deeper the lesion will become, and that's very important. When you use this platform, you will have the same pedal. You start the ablation. The system will deliver the pulses systematically, and you can go up to 24 pulses with this catheter. After 24 pulses, you will see a plateau, so you don't see any further, like biologically relevant lesion formation. And certainly there is a correlation between the number of impulses and the number of bursts or the lesion depth. But the second thing, which is very important, and if you want to translate it down to your clinical setting, is that there is an association with the contact force. And it's not just a yes-no. I think in the morning somebody mentioned that with PFA, contact force is not relevant anymore. If you have some contact, it's enough. That's definitely not true for STSF. This is a nice study published by Nakagawa, and they made different lesions with different burst impulses and contact force groups. In the low group, they used 4 to 15 grams. In the middle group, they used 16 to 30 grams. And in the high group, they used 30 to 65. And as you can see, if you're in the low contact force range, which some operators are realistically are, then you can't get an extra benefit after 18 impulses. Okay, so if you go to 24 in the first column, you won't see any meaningful increase in the lesion size. So that tells me that if I want to use the system efficiently, I probably will have to stick to 15 to 30 grams. Probably wouldn't go over 30, or we'll be extra careful with that part. Okay. Now, if you have the data, you can plot it on a multivariate regression model, and you can kind of predict the lesion size based on the contact force and the number of impulses. And if you reverse engineer it and you reverse engineer your thinking, you can come up with a PF ablation formula, which will be very familiar to you because everybody is using the ablation index formula. It's essentially the same thing, but it's designed for the PFA impulses. Okay, so if they reversed, their mindset and they wanted to target 3.5, 4.5, 5.5, or 6.5 millimeters lesion depth, they could quite accurately do that. If you look into the other slide, you can see that you can get a 1.5 millimeter accuracy in 99% of the cases. So that tells me if I'm trying to achieve 6.5 millimeters with this catheter, then I 100% will get 5 millimeters, which is probably enough in the left atrial setting in most of the cases. And finally, just a quick thought about, delivering RF and PFA in the same location. So this is a nice data which shows that with this catheter, if you deliver PFA on top of RFA or RFA on top of PFA, you get an extra lesion depth. And in this scenario, you can increase your lesion depth from 4 or 5 millimeters to 6, 7 millimeters, which is again a good indication that if you're trying to create a roof line, say in the left atrium, that might be the strategy you will use. Or if you're trying to create a mitral isthmus line, there might be an extra benefit for creating the double lesion. So let's move on to the clinical data. And as I said, the only data today what we have is the SMART-FIRE trial. It was a prospective study. It wasn't randomized. It was observational. Roughly 150 patients were included. And the ablation procedure was a PVI procedure only. In selected cases where atrial flutter was documented, the operators were allowed to do a CTI line. And the idea was that you had to do the PFA lesions on the posterior wall, and you had to do the RF lesions on the anterior part, and you had to use an ablation index or a PF index of 400 on the posterior and 550 on the anterior wall. The primary endpoints were safety and acute effectiveness. In 100% of the cases, acute PVI was reached. 97% of the cases, there were no acute reconnection per vein. And yet, if you're looking into the 3 months data, the 3 months per vein analysis showed around 87% durability on pulmonary vein isolation, which is probably close to or in line with the previous data that was shown by Peter. Now, it had quite interesting safety assessments. We had to do esophageal endoscopy in 31 patients, neurological assessment, including MRIs in 30 patients. We were checking PV stenosis in 30 patients. And as I already mentioned, there was remapping done in 30 patients. In terms of safety, and I'm going to show it later, there are a few cardiac tamponades. One patient had a stroke, one patient had a pericarditis. But unfortunately, during the study, we've seen 2 PV stenoses, but I'm going to go back to that probably later. In terms of procedural data, 4 minutes of fluoroscopy time and around 100 minutes of procedure time was the outcome of the study. So if you're looking at the 3 months outcome, and you're looking at the neurological assessment, I already mentioned one patient had a stroke, but luckily that patient fully recovered, and the repeat MRI didn't show any long-term chronic lesion. And we picked up one silent cerebral embolism in one other patient. I'm going to discuss the CT findings on the pulmonary veins. As you can see, one patient was picked up with an asymptomatic pulmonary vein stenosis at 3 months, and another patient had a symptomatic PV stenosis which needed intervention. What is very important that there are no signs of any esophageal damage in the endoscopic data. And if you're looking at the durability analysis, and that's quite important, the majority of the reconnections were at the right posterior part of the line. And I think one of the reasons for that is that the stability in that point can be sometimes quite bad. This application, especially the posterior wall, can last for 15 or 20 seconds, and sometimes it's quite challenging to get a good contact. And I think that was one of the takeaways from the 30 or 3 months data. If you're looking at 12-month effectiveness, with stringent monitoring, you get around 70% success rate. If you forget the remote devices, then the success rate is around 80% or a bit more, which is in line with the average studies, I think, today. Certainly, if you stick to the protocol, and we had a sub-analysis on that, if you're more compliant with the protocol, you get better results. If you're less compliant with the protocol, then your results are not as good. Safety at 12 months, which is slightly different from the 3 months data. At 12 months, I already mentioned the pericardial tamponades. One patient had an anaphylactic shock, which is very unlucky, but probably not the device related. And as I already said, altogether 2 patients had a significant PV stenosis. Now, if you look into the cases, so 2 patients with symptomatic and 1 patient with asymptomatic PV stenosis, the conclusion from the steering committee was that the PV stenosis were most probably related to RF applications, and most probably related to RF applications too deep or too stacked lesions in the vein. Which is very important to keep in mind. So if you use this technology, and I think we are very comfortable with the other technologies today, and if we use the other big shot PFA systems, we just don't think about PV stenosis anymore. If you use this technology for PVI, always keep in mind that that's a possibility, unfortunately. So just to conclude, and these are my thoughts, and I think we still need some clinical data and experience, but it seems like that the dual energy STSF catheter is capable of delivering and chronic PFA lesions. The lesion size is clearly related to contact force and the number of PF applications. On a positive note, you will have a PF ablation index, so you can exactly dose your lesions, and that will predict your lesion size quite accurately. Again, very interesting and needs a bit more further clinical data to back it up, but it looks like if you stack a PFA lesion on top of an RF lesion, you might get a deeper lesion. And in terms of pulmonary vein isolation, this technology is capable of producing the same outcomes data as the other technologies in the market. Safety profile is good if you're thinking about the esophagus, the phrenic nerve, or the SCAs, but bear in mind if you're using RF for the anterior part, then the PV stenosis is still a possibility. And I think in my mind, this catheter has a very good potential on doing a lot of other cases is on, beyond the PVIs, but certainly we will need to get more evidence or data on that. So with that, I thank you for your attention, and again, thanks very much for the invitation.
Can I comment? A great presentation. I must tell you, for the sake of time, I'll just say what I think. I think, bioscience haven't figured out the pulse field. Because I do feel that, to have a stroke in a relatively small number of patients, you can, and probably using similar sequences like the varipulse, does raise a red flag. I must say, I don't think we can dismiss it. The second thing is that the rate of reconnection on the posterior wall is high. It's relatively high, and it has to do exactly, I think, with what you said, is a sequence that you have to stay stable for 20 seconds. And I worry that if they used PF, if the protocol, I'm not sure why they didn't do it, if the protocol called to do a whole PFA, I think you're going to see significantly worse results, because I don't think the PF would be as durable on thicker tissue, where it wasn't very durable on thin tissue. I'm just worried about this. That's why.
I mean, you might or might not be right. I think to start with the second point, you will have a clear answer in a reasonably short amount of time, because I think Tom de Potter is investigating that question. If you think about, I fully agree, the contact force is very important. If your catheter moves, then you might not get a lesion. On the anterior part, usually you get a good contact, so I'm not sure, but we have to see. But I take the point. On the strokes, one stroke in 150 patients can be coincidence. Looking at the 30 days silent cerebral embolism data, that's not too bad. But I guess your point is well made.
I think if you compare it to the closed protocol, which was a large study, all RFA, you have more durability and you had better clinical outcomes. So,
personally, I can agree with a lot of things. I don't think personally I would use this catheter as a workhorse for my PVIs. So you might be right in one way, but I think this is too early days and you still have to see the data.
I think it's an early iteration of something that's probably going to be very successful, but not yet.
I can have comment. I think the main potential of this catheter could be for some focal lesions in ventricle, like summit or great cardiac vein, papillary muscle maybe. So I don't see now the reason to go back and start to ablate with pulse field point by point with small catheter. If you have now all companies have large footprint stuff, which makes it much faster and safe, efficacious.
That's true, Josef, and I completely agree with you. But if you look at even in the European scale, you and I might be in a privileged position to have access to multiple PFA technologies, but there are still other centers in Europe which don't have access to any PFA technology, and for those centers, we are using RFA today. Maybe.
Anybody tried in ventricle this catheter?
No, there is a study ongoing, and a VT study is ongoing, and there's no results yet.
Okay.
Yeah, but I agree. I think for me it's the same thing. Probably different. I wouldn't use it for the PVI on a routine basis.
Okay, so maybe it was a very interesting day. It was a very long day, and it's time to wrap up. Hopefully, we will all rejoin for the social meeting and party, as Peter said.
Thank you, Peter. Thank you, everyone.
Good evening.